Can I have a pointer, please? So good morning, all. This is the first talk of this session on procedures, and one of the important procedure which we do in uveitis is aqueous paracentesis. So basically, we remove the fluid from the anterior chamber and send it for examination. So let's look at a few cases. This is a 56-year-old diabetic with a 1-week history of recent cataract surgery, and at the end of 1 week, she develops intense fibrin like this, and even with topical steroids, the contraction is there, but it doesn't settle down very well. And if you notice carefully, along the wound there is a keratic precipitate which has developed. And so these are cases which need to be tapped, and the fluid, we normally send it for PCR to rule out infection. And if there is, usually the stain and cultures are negative, but we do send them as a routine in these cases. And this case turned out to be positive for Pseudomonas, and we were dealing with a patient with post-op endophthalmitis. This is another case, and if you see carefully, there's a lot of pigmented keratic precipitates, and these are all active. And if you look at the pupil, there is an iridoparesis which is there. Or this is another case where you have a corneal involvement with keratic precipitates along the cornea. And this is a patient with Posner-Schlossman where there is a sudden onset of increased intraocular pressure and inflammation. So when you see there are few cells and very few KPs in the anterior chamber. But what is significant in all these cases is increase in intraocular pressure. So whenever we see a condition like this with increase in intraocular pressure, it is always important for us to tap this eye and send the sample for examination, mainly to rule out viruses. This is another patient with Fuchs heterochromic iridocyclitis, which otherwise we do not do any other investigations. But if this is associated with increase in intraocular pressure, it is important to tap these eyes to look for viruses. This is one of one 70-year-old lady who came to us with corneal changes, and then there was something like a hypopyon in the anterior segment, and she had a total cataract. So we didn't know what was going on, and these are cases which you need to tap, and this turned out to be actually a lens-induced inflammation, and if you can see, these are the macrophages which were swollen with the lens material. So a lens-induced uveitis is another indication where we do tap these eyes. This is a 30-year-old male who presented with diminution of vision in the right eye of 1 year duration. And if you see carefully, there are some structures floating in the anterior segment, and there were a lot of iris changes. And on the lens also there are changes. In the posterior segment, you have something like a subretinal granuloma. And intraocular pressures were very high. And when we tapped this eye, this turned out to be a microfilaria. And a blood smear when we did, this was actually a patient with filarial infection. And these were the ocular manifestations which picked up the systemic filariasis. So the indications broadly will need to rule out infection, and the most common indications are to rule out endophthalmitis, viral infections, toxoplasma, and parasitic infections. Another important indication is if we need to rule out masquerades, and the most common or the most important being the intraocular lymphoma, where we look at the interleukin levels in the aqueous. So these are the tests which we do from the fluid which we obtain, and the most common test which we normally do is the PCR. Along with this, we also can look at the antibody synthesis, what we call as the Goldman-Whitmer coefficient, and this is quite useful in patients if you're dealing with conditions like toxoplasma and rubella, where we look at the antibody levels in the aqueous as well as in the blood. And the third thing is cytology to rule out masquerades, and flow cytometry, where we look at the interleukin levels. This is mainly for intraocular lymphoma. Ideally, the tap should be done when the disease is active. And these are the instruments which we routinely use. This is an insulin syringe for the tap. So this is a small video on how we do a tap. So we anesthetize the eye, and with an insulin syringe, which is a 30-gauge needle already attached to the syringe, you enter the eye, and you can stabilize it with a pledget from the other side with the bevel up, and then you remove the aqueous. This can be done either by pulling the plunger, or it can be done by a passive way where you just remove the plunger and you can just use a pledget to just push in the aqueous through this. And then you put in some antibiotics and then you patch the eye. See this eye again after about half an hour to see if the chamber is well formed. Now, this is what we routinely use in our practice, but there are different instruments and devices which have been there and which does help in removing the aqueous from the anterior chamber. And these are innovations which are done. Basically, you want the entry to be smooth, and you want the resistance and the distance which the aqueous travels to the syringe to be also shorter. So these are the different innovations which have come in and being used for aqueous paracentesis. One is a paracentesis pipette. This is another from the Japanese, where they have done a very short needle and a plunger which is there. And this is the minim, where it is filled with saline. So you just press that, and when you release the pressure, the aqueous automatically enters the eye. Now, it is relatively a safe procedure, done in experts' hands, but you still need to be careful. Complications are very rare, and the most common is hyphema. This is a video which shows many of these cases also have new blood vessels in the ankle. So when you tap the eye because of sudden change in the pressure, you can see a bleed which is coming in. This is the Amsler's sign. So you can also have 1 day post the tap, you can see hyphema in some cases. You can see fibrin. You can have an injury to the iris tissue, especially if the anterior chamber is very shallow. You can have a lens touch, so you need to be a little careful. It's very rare. If it is done under aseptic precautions, this is very rare, but you can have a needle track abscess. Sometimes if the paracentesis is not, if the angle is not okay when you enter, you can have minor leakage from the paracentesis side. And in patients who have very high pressures, when you tap these eyes, you can have a sudden hypotony and you can have retinal hemorrhages. And this is a very, very rare complication which can occur. So to conclude, aqueous tap is the most useful procedure for diagnostic purposes, especially in conditions like uveitis, and it is very safe in experienced hands. And the procedures which we normally do when we get the fluid is microbiology, cytology, molecular analysis, antibody synthesis, flow cytometry, and we can also use this sample to save for future research purposes. Thank you very much.
Thank you, Dr. Kalpana. A small question. How much fluid should we take out, and how much is adequate for a microbiological and PCR?
Yeah, so usually in the insulin syringe, about 1 unit you can easily remove, and it doesn't cause much of a collapse in the anterior chamber as well. But if you see a lot of change and if you feel the chamber is shallowing, we could stop. The problem comes when you're dealing with, if you're sending it for viruses, and DNA and RNA viruses, then they require a larger amount of fluid. So nowadays, multiplex PCRs are available, which has made it a lot more easier. But generally, about a unit should be okay.
And for microbiological?
Microbiology, we always have a problem. No matter what you send, they say the sample is insufficient. So nowadays, we are relying more and more on the PCR. And if possible, and whatever fluid is left, we normally send it for cytology and microbiology.
Thank you so much.
Yeah.